Okay, so we're going to go ahead and get started with the week 7 information. We're going to start with conditions of the blood. Um, so one of the things that you need to make sure that you know when we're talking about the blood or the different parts
Different
of the
parts
blood.
of the blood.
Oh, someone's
Some
not on mute. Okay. Um, so you need to be able to recognize the different parts of the blood, the red blood cells, white blood cells, the platelets. This term here, discar Dyscarasis just refers to disorders of the blood. So this can be any part of the blood where there's a disorder. This is a general term to describe that. Um, and then something that you need to make sure that you remember is that this hormone here on the bottom of the slide, red blood cell production, is regulated by erythropoietin. So this is a hormone that stimulates the body to produce red blood cells. So you also can give this medication subcutaneously to patients, for example, that have leukemia or they're not producing enough red blood cells. You can give this as a medication, and it does the same thing where it stimulates the bone marrow to produce red blood cells. So in addition to the blood, there is the lymphatic system, which is the system throughout the body, involves your spleen, your lymph nodes, that is involved in fighting infection. So the spleen is the largest part of the lymphatic system, and blood that contains pathogens potentially comes in contact with white blood cells in the spleen, and then that is part of fighting an infection. So sometimes you'll see the spleen enlarged when a patient has an acute infection. You can also see lymph nodes enlarged. So for kids, if they ever have an enlarged lymph node, that you should be concerned about infection. You shouldn't be able to palpate lymph nodes in children that don't have an infection. So when we talk about the circulating blood, there's really two different components. There's the plasma, which is the liquid part, and then there's the formed elements, which are going to be your erythrocytes, which is the other name for your red blood cells, your leukocytes, which is another name for your white blood cells, and your thrombocytes, which are your platelets. So these three terms here that are listed on this slide, erythrocytes, leukocytes, and thrombocytes, you need to know what those mean. You need to make sure for your next test that you're able to identify erythrocytes or red blood cells, leukocytes or white blood cells. Erythrocytes, or red blood cells, they are the cell in the blood that carries oxygen to the body, and also they help get rid of carbon dioxide. But when we think about red blood cells, this is the oxygen carrying transport molecule of the blood. So when we're talking about anemias, et cetera, we're talking about problems with the red blood cells, and particularly hemoglobin, which is a protein on the red blood cells. And then leukocytes and lymphocytes are both involved in fighting infection. So the most common sort of anemia is going to be your iron deficiency anemia. So anemia is a general term that we use to describe, not having normal hemoglobin or abnormally low hemoglobin. It causes pallor, which is pale, weakness, tachypnea, shortness of breath, and congestive heart failure. So these are going to be symptoms that you see kind of long term. You don't necessarily see these symptoms right away when someone has anemia, but over time they can develop congestive heart failure. Does anyone want to think about this with me? Like why would you develop congestive heart failure if you had anemia? What would the heart do in response to having a low hemoglobin level that would cause congestive heart failure? What
The
do you
heart
think?
is carrying less oxygenated blood.
So that's
The
part of it. The heart, yeah, you're right. So right,
heart
the heart
works
itself
too
needs
hard.
oxygen. Yeah. And what's something else? So the heart itself isn't getting the oxygen and the need. And how would your body respond to not having enough oxygen carrying capacity?
The heart works too hard
The
because
heart works too hard, right? It has to pump more blood to get the oxygen out there. So if you just think about, you have like a lower concentration of oxygen in your blood, so then you have to send a higher quantity of blood to that target tissue. So it causes that tachycardia, and it over time will lead to congestive heart failure. So it is, we don't always think about anemia as being something very serious, but it certainly can lead to something serious like congestive heart failure if it's not treated over time. So just to really be aware that the long-term consequences of anemia can be really severe, the most severe really being this congestive heart failure. So like I said, iron deficiency anemia is the most common form of anemia in children. And, there's a couple things, you can have iron deficiency anemia just from blood loss. You can also not have enough iron consumption in your diet. And this is one of the things we talked about earlier in class, that giving cow's milk to infants can lead to GI bleeding, which leads to anemia. And it also, cow's milk doesn't have the same iron concentration as the formula, that they're able to digest better. So you're certainly going to consider, a child under the age of 1 that's drinking cow's milk. That is a risk factor for iron deficiency anemia. So this kind of goes over again what you would see with iron deficiency anemia. Obviously, you're going to have decreased activity because they just don't have the oxygen that they need to really be active. It's common that you're going to, do a hemoglobin hematocrit level to see where they're at, look to see what this morphological cell change is, kind of what the cell looks like. You also might be looking at their iron stores. Sometimes you'll test the stool for a pulp blood. So there's a couple different tests that you would expect in a child that's being evaluated for iron deficiency anemia. So this is what I was talking about earlier, that if it's untreated, it can lead to pretty severe consequences. You usually, once you treat it, typically you would start with dietary modifications, making sure that they're under 1, that they're not drinking milk, maybe encouraging the parents to encourage more iron-rich foods in the diet. If you start with an iron supplement, it's usually 2 to 3 times a day. So vitamin C aids in absorption. So if they're old enough, taking it with orange juice is a good idea. If they're not at the age where they're drinking orange juice, then you would give it on an empty stomach, because that's when their acid concentrations would be the highest and they would be the most likely to absorb it. So when you're doing your anticipatory guidance with your parents, we always recommend breastfeeding, and then recognize that if that's not possible, the iron fortified formula is also a good option. You don't want to give the iron with the milk. That can alter the absorption, and you want to make sure that they're not drinking any cow's milk before the age of 1. So sickle cell anemia, or sickle cell disease, is a genetically inherited form of anemia. Has anyone known anyone with sickle cell disease, or do any of you have any experience with sickle cell disease?
Yes.
So
My
do you know
cousin-
someone? Go ahead.
My cousin died from that.
Oh, okay. So it runs in your family?
She was the only one that had it.
Oh, okay.
She's
And what
around
can you tell
36
me
years
about
old.
what happened? Was she diagnosed young? What happened with her?
I think she was around 9 years old when she was diagnosed, and
Okay.
the doctors told her that she won't live past probably 11, but she died around 36 years old.
Oh, wow. Okay. So sickle cell anemia, or sickle cell disease, is a problem with the way that your hemoglobin is shaped. So hemoglobin is the protein on the red blood cells that carries oxygen. So oxygen binds to hemoglobin. So they're misshapen, they're sickle shapen, so they're kind of in a crescent shape. And they don't have the same ability to bind oxygen. And this causes a lot of different problems. First of all, it causes clumping. So because the hemoglobin is misshapen, the red blood cells stick together. And then they cause clots. So, you have a lot of small blood vessels in your body, and then blood can't get through those clots because they're all clumped together. It also makes the red blood cells more fragile. They get destroyed more easily. So it causes a lot of problems. And usually, it's more common in the people who are descendants from Africa. So a lot of times people know if it runs in their family, but it's one of those things that, sometimes people don't know, and it kind of comes out of the blue and they don't know it. So they do need lifelong treatment. And, depending on how severe the disease is, some people live fairly normal lives, and then some people have a lot of medical problems. So it is genetically inherited. So you get if you only receive the gene from one of your parents, then you have what's called sickle cell trait, where if you get the disease or the gene from both your parents, then you develop the disease. So you can have some milder symptoms if you only inherit it from one parent. So, our classmate, 9 is fairly old to be diagnosed, usually pretty early in childhood, even in parents that don't know that they're carriers. You might see some swelling in the fingers and toes. And sometimes, other problems in terms of like just not feeling well. They can get pain, respiratory infections, so usually it's kind of the swelling in the fingers and the toes and the pain, which is the first thing that kind of clues people in there might be a problem. One of the things that you need to remember with these patients, because they have that propensity to clump their red blood cells, is that they always, if they're having problems with sickle cell crisis, which is the painful crisis where they're not able to get blood past those blood clots, then they need IV fluid to make sure their blood is staying nice and thin and more likely to get past those blood clots. So there's a couple of different types of crises. So the vaso-occlusive, this is the misshapen hemoglobin causes the red blood cells to form clots, and then blood can't get past those clots. There's splenic sequestration. So these clots can also form in the spleen, and then the spleen is not able to function normally. Aplastic crisis refers to crisis of the bone marrow. So your bone marrow is responsible for producing your red blood cells. So when you have an aplastic crisis, your bone marrow itself is in crisis and not able to produce, the formed elements of the blood that you need. And then hyperhemolytic, this refers to a rapid destruction of your red blood cells. So the most common is going to be this vaso-occlusive crisis. This is the thing that you're going to see most common with the sickle cell patients, and that just refers to those clots that form in the small blood vessels, and then the blood can't get through, and it causes a very painful crisis and also ischemia distal to that blood clot. So this is this hormone that I mentioned in the beginning of class, the erythropoietin. This is a hormone that you naturally produce, and sometimes they give it to patients that have sickle cell disease to encourage the production of more hemoglobin. Sometimes they will end up doing a splenectomy, but it's not recommended, routinely. A lot of patients who have sickle cell disease will have problems with their spleen, but they just leave it and let the disease process continue on its way. They are at higher risk for infection, in large part because their spleen frequently doesn't work well. And if they get dehydrated, they're more likely to have a sickle cell crisis. And when they're sick, they need additional oxygen because they don't have the same capacity to carry oxygen throughout the body. And this, because of the sickling and the blood clotting, they're more likely to break down their red blood cells. So this medication, deferexamine, helps get rid of the iron. So your hemoglobin contains iron, and when you're constantly breaking those cells down, you get iron deposits throughout your body, which can also be damaging to your organs. So this medication, deferexamine, is used to break down the iron. Does anyone have any questions about sickle cell anemia before we move on to the next genetically inherited anemia? Okay. So thalassemia is another type of anemia. This is not as common in the United States as sickle cell anemia. This tends to be more prevalent in people of Mediterranean descent. It is kind of similar in the sense that it's genetically inherited. The red blood cells are an abnormal size, and they also break down very, very easily. So they have some similar problems in the sense that they end up with deposits of iron throughout their body that can cause damage to their organs. So there's two basic forms. It's very similar to sickle cell in the sense that thalassemia minor means that you just inherited the gene from one parent, whereas thalassemia major means that you inherited the disease from both parents. That's called Cooley's anemia also. And there are some instances where it's a spontaneous mutation, but it's usually a genetically inherited disease. So thalassemia minor, sometimes they're asymptomatic. They might not know that they have any problems, or they could just have a mild anemia, or they could be misdiagnosed as having iron deficiency anemia. Most people with thalassemia minor live a pretty normal life, and they don't even know that they're a carrier. Whereas the major is quite a bit more. They have progressive anemia. They are really diagnosed almost always during infancy. They have, you know, the sequela of not having adequate oxygen. They're hypoxic. They're more prone to infection. They don't eat well. They tend to be pretty sickly. And they have, like I said, they tend to break down their red blood cells very, very quickly. So they get the enlarged spleen. They can also end up going into cardiac failure. This is one of those instances where you would really see the congestive heart failure, because the anemia is really profound. So the basic treatment for thalassemia major is just repeat blood transfusions. And because they're the bone marrow is responsible for producing the blood cells, they can actually end up with abnormalities in their skeletal system because of they're constantly trying to compensate and produce more red blood cells from their bone marrow. So, like I said, it can be a genetic mutation, but it almost always runs in family. And this is the one where, you know, you're going to just do repeated blood transfusion. There really isn't anything else that you can do. And they also end up with the iron deposits because of their frequent breakdown of their red blood cells. They may end up getting a splenectomy. It depends on how severe the disease and what condition their spleen is in. And they may also take the iron chelating medication to help get rid of the iron deposits in their blood. So whenever we're talking about kids that have chronic illness, if you can try to make sure that they always have the same nurse when they come into the hospital, that's ideal. They'll get to know the family better. They'll have a better relationship with the family. This is one where they're going to frequently have blood transfusions. So what are some things that you guys can tell me? What are some things that you do as a nurse? I know you guys are going to be LPNs, but what do you monitor for during a blood transfusion? What are the things that you look for?
Increased temperature.
Increased temperature is one of the main things. And why you care about increased temperature when someone's getting a blood transfusion?
Because that can insinuate a reaction to the blood products.
Okay. And so increased temperature, generally monitoring their vital signs, monitoring for itching. Something that sometimes happens is sometimes they complain of a backache, which isn't necessarily that common, but sometimes a backache is an indication of a reaction to the blood. So I know that as LPNs, you guys are probably going to potentially be monitoring somebody that's getting a transfusion. I think in most states, registered nurses are the only ones that are allowed to start it. But you need to still be aware of the basic things that you monitor for. You want to make sure that it's the correct blood match, that you do like the ABO, RH anemia. So you have your iron deficiency anemia. Your Cooley's anemia. So I apologize. I looked up and everyone's camera was off, and I realized it was my problem, not yours. So So I want to make sure that you guys know that, in terms of the anemias, there's the iron deficiency anemia is the most common, and that's going to be followed by your sickle cell anemia, and then less common is your thalassemia major and your thalassemia minor. And regardless of the type of anemia, you're going to be looking for like the long-term symptoms are going to be that your congestive heart failure is the thing that you worry about the most. With both the sickle cell and the thalassemia, you have to be concerned about the sequela of repeat blood transfusions and also repeat breakdown of red blood cells causing the buildup of iron throughout your body. So now we're going to move on to bleeding disorders. So these are going to be your hemophilias. So when you have a hemophilia, you don't produce a clotting factor that you need in order to form blood clots. So this is one of these, X-linked, we call it. So it's the mother is the carrier and then the son has a disorder. So you're going to see this in boys and not girls, but it runs on the mother's side of the family. And the main thing that you need to remember about hemophilias is that whatever clotting factor that they're missing, you replace that and that fixes their problem. And there's a couple different forms. But the main thing that you need to remember is that there's a wide variety of symptoms. Some people have really severe hemophilia where they really can't play sports or anything like that because they could bleed to death. And then some people just need a little bit of extra pressure when they bleed because they don't clot quite as easily. But regardless of where they fall on that spectrum, the treatment is going to be replacing the clotting factor that they don't produce. So a lot of times, there are a lot of things that cross the placenta. So you can't normally test them right when they're born because they're going to have some of their mom's antibodies or cells from their mother. But the clotting factors don't cross the placenta. So if you're concerned about hemophilia as a newborn, you can test it right when they're born because they'll never have their mother's clotting factor. So that'll just be, if they have hemophilia, you'll be able to check it because they'll be missing that clotting factor. So it can be quite deadly, depending on where they fall on the spectrum of what clotting factor they're missing. So you need to make sure that parents have the education that's specific to what is wrong with their child, because there's a very large spectrum where some people can bleed to death easily and some people just need a little bit of extra pressure if they have a cut. So a lot of times it's one of those things that's genetically inherited. People might know that they're a carrier, but if you're doing work with a family and they complain that their child has a nosebleed that doesn't stop, or they get a bruise whenever you give them immunization, or they end up with lots of joint pain and you do an evaluation and they have bleeding into their joint cavity, all of those things could be signs that they have undiagnosed hemophilia. So always be on the lookout when you're working in pediatrics, and you should almost always believe the parents. They know their kids really well, and if they're telling you something is wrong, then you should believe them. And something simple like they really get on a lot of nosebleeds, that could actually be an undiagnosed hemophilia. So I mentioned this, that the principal therapy is going to be prevent bleeding. So kind of knowing what their risks are, and then you replace the missing factor. A lot of this can be done at home now. They have, kids that need factors replaced. They can have central lines or ports, and the parents can be taught how to give the medication. They're going to be followed very closely by a hematologist that manages their levels and their medication doses. So you do need to be aware that the main thing is that you replace the clotting factor. There is, depending on what clotting factor they're missing, it's usually given IV, but there is a nasal spray, DDAVP is prescribed to some patients that can stop the bleeding. It gives the clotting factor through their nasal pharynx. And then making sure that the parents know all of the precautions they need to take if they're going to be allowed to play sports or not allowed to play sports, if they have to have surgery, what sort of lab work do they need prior to surgery, because they're going to be at risk for bleeding. So this just kind of goes over, it's always going to be a multidisciplinary team. Sometimes parents can be really overprotective, which makes sense. So you need to kind of find that balance, making sure the kid is able to live a normal life as possible while taking into consideration what their risks are for bleeding. So hemophilia is when you don't have a clotting factor that you need to form blood clots. You can also have platelet disorders. So platelets are also involved in forming platelets. So this tends to be less severe. It's um, you can give, depending on the situation, you can give missing platelets. Sometimes kids will have a platelet disorder just when they have a viral illness, but it doesn't seem to have the same degree of like risk of sudden death from bleeding to death as the hemophilias. There's a very specific type of platelet disorder called ITP, which is your idiopathic immunological thrombocytopenia. It's it's not really totally known, but it usually happens after a viral illness. So they have like an autoimmune reaction after a viral illness where their body attacks their own platelets. It usually goes away on its own, and they present with purpura or petechiae, and then they do a platelet level, and the platelet level is low. So you could see the bruising or the petechiae and purpura. It's common, like I said, that they've had some sort of respiratory infection prior to developing the ITP. And depending on the severity, they might do a bone marrow aspirate to confirm the diagnosis. They generally do not give platelets because the body is in the process of breaking down platelets, but they might give steroids or medications that you would see for an autoimmune disorder to kind of tamper down the response. But because they are at risk for bleeding, your neurological assessment is going to be a priority of care. So whenever you think about bleeding, you could potentially bleed into the brain, have increased intracranial pressure. So if you're ever asked any sort of a priority question, you would need to pay attention to their neurostatus if they had ITP. Sometimes, like I said, they'll give prednisone or other medications used to treat autoimmune disorders. And then you can have chronic ITP, but it's usually a self-limiting illness that happens after a viral infection. So all of these drugs here increase your risk of bleeding. So you want to make sure that you avoid these drugs when a patient has ITP. And I mentioned this, but it points this out on the slide. Platelets are usually not given because it's an autoimmune reaction where they're breaking down platelets. So if you give them platelets, they will also break down those platelets. So it usually is not a big deal. It usually is like they have a transiently low platelet level as an autoimmune response to a viral illness, and then they get better. But they can have bleeding into their brain. They can have bleeding into their joints. They can have GI bleeds. So any place in their body that they could bleed, that is a potential complication of ITP. And then generally speaking, making sure that your patients are up to date on their immunizations is a good way to prevent ITP because it almost always is after a viral illness, and then they have the autoimmune reaction to the viral illness. Does anyone have any questions about that? Trying to manage our time here. I have a quick Kahoot. I was going to have you guys do discussion questions, but I think I'm going to have you guys do the Kahoot. So let me pull the Kahoot up really quick. Then you guys can take another small break and then we'll So what food is rich in iron? Bananas, carrots, cream of wheat, or egg whites? All right, so a lot of you got that fine. Someone sent me a message you can't hear anything. Are you guys able to hear me okay? Yeah? Can
Yeah.
you give me the thumbs up?
Yeah,
All right.
now
Yeah.
we can.
Okay, sounds good. So yeah, carrots, not necessarily. Egg whites, egg yolks are okay in iron. Banana, not so much, but cream of wheat, yes, it's a good source of iron. Which statement by a mother may indicate a cause for her 9-month-old iron deficiency anemia? I gave her a cracker to chew on. Formula is too expensive, so we use cow's milk. She eats a lot of fruit, or she almost never drinks water. Right. So kids, you're going to worry if they're getting cow's milk before a year. They can't digest it. It can cause microscopic bleeding. It also doesn't have the same iron as the iron fortified formula or the breast milk. So what should the nurse closely assess for in a child receiving a transfusion? Lethargy, fever, jaundice, or bradycardia? Right, very good. It's fever. You're gonna be worried about transfusion reaction. You're gonna be paying attention, fever, itching, maybe some back pain. The nurse notes that a 4-year-old child has been bruising and petechianous extremities. What lab value does the nurse suspect? A leukocyte count of 14,000, a hemoglobin of 8, a hematocrit of 36%, or a platelet count of 25,000. All righty, so this was one that you guys struggled with a little bit. So the petechiae and bruising, this is going to be associated with maybe your idiopathic thrombocytopenia, your ITP. So this is going to be something you're going to be worried about a platelet count. So this 25,000 is a low platelet count. This is a sign that they're not able to form clots because their platelets are low. So that is your right answer there. So a child is diagnosed with iron deficiency anemia. What will the nurse explain can occur if the disorder goes untreated? Heart failure, pulmonary embolism, infection, or hemorrhage? So it is heart failure. Good job, you guys. This over time, their heart has to work harder because they don't have the same oxygen carrying capacity. Nice job. So a child with leukemia has widespread purpura and a platelet count of 19,000. What is the priority nursing intervention? Place a PIV, assess the neurological status, monitor vital signs during a platelet transfusion, or educate family on preventing bleeding. All right, so this one was a little bit tricky for you. So leukemia we didn't talk about, but anytime they have a low platelet count. So this is a very low platelet count. You have to be worried about bleeding, and then bleeding, you're always primary concern is, are they bleeding into their brain? So anytime you're given a priority question with somebody that's increased risk for bleeding, kind of regardless of what it is, your neurological status is going to be your priority to make sure that they're not having any sort of an intracranial bleed or an increased intracranial pressure. What would the nurse include in the teaching plan about a child receiving chemotherapy? Use the soft toothbrush, avoid using a water pick, inspect the mouth weekly for ulcers, or use a commercial mouthwash. All right, so good job. So chemotherapy, they're at risk for sores in their mouth. You want to look for mouth ulcers a lot more than weekly. They usually have a special mouthwash to kind of help with the pain of their ulcers. A water pick is good, but you do want to make sure they use a soft toothbrush so they don't damage their gums at all. So good job. So an adolescent with Hodgkin's disease is crying and states, "I'm so scared." What is the best response by the nurse? "You shouldn't feel that way. I understand how you must feel. Tell me what's got you so scared, or you should talk to your parents, not me." So good job. So this one, you really should be able to answer without even knowing what Hodgkin's disease is, because you want to encourage the adolescent to talk to you, to open up. So you are going to say something kind of open-ended and make sure the adolescent knows that they can trust you and you're open to talking about why they're scared. The nurse is caring for a child with a low platelet count. What skin assessments would alert the nurse to bleeding? Ecchymosis, hematoma, petechiae, or all of the above? Yeah, so it is all of the above. So good job, you guys. I'm going to give you just a quick break. So it's 11, we'll say it's 11, I'm sorry, 10:15. So go ahead. Let's look at the podium here. Good job, everyone. Who's Beagle? Which one of you is Beagle?
It's me.
No one wants
Kim.
to own up to me. Ah, very nice. Very good job, everyone. So we'll say it's 10:15. Go ahead and come back at 10:20 and we'll do the last chapter. So you have like a 5-6 minute break here. Okay, so when you come back from your break, if you go ahead and flip your camera back on, then I'll know that you're here. Thank you very much. There's still a couple of you, Tamu and Michaela. If you could go ahead and flip your cameras back on for me. Okay, so hopefully you guys can still see my screen. If you can't see the PowerPoint, please let me know. I think I left it on. So we're going to talk about the gastrointestinal tract now, which is the last chapter for the day. The GI tract is a really long tract. It extends all the way from your mouth all the way down to your anus. So there's a lot of different, things that happen in your GI tract. The main purpose is to break down nutrients into absorbable products that then can be used by your body. And usually, most of the time when we talk about the GI tract, we think about local signs when there's a problem like pain, vomiting, diarrhea. There's something like specific area of the GI tract where there's a problem, but there can be systemic signs. So systemic signs mean there's a problem that you see throughout the body. So a systemic sign of a problem with the GI tract, the most common would be failure to thrive. And you can also have itching. So if there's a problem with your liver, you can have itching, and you can have itching all over your body, not just in a localized area. The most common signs that there's something wrong with your GI tract, however, are the local signs. So, when we're talking about your nursing priorities for somebody that has a gastrointestinal problem, it's preventing malnutrition and making sure that they are not dehydrated, that their electrolytes are stable, and that you're optimizing their nutrition. And if they have any pain or discomfort, you would also need to address that. There are certain congenital disorders. So congenital just means that you're born with it. So there are certain problems with your GI tract that you are born with. One of them is this tracheoesophageal fistula, and that's a TEF. So you don't need to know all the different types. This is for your reference here, but you're not going to be tested on this. The thing that you need to really remember about TEF is that there's a communication between the esophagus and the trachea. So they sputter and they cough, etc., when they eat, because the esophagus either doesn't drain into the stomach or it communicates with the trachea. So this is something that a lot of times they're not diagnosed before they're born, but the first time they go to eat, they cough and they sputter and they have a hard time eating their food. And they do need repair early in life, because they're not, when they eat, that the nutrients aren't going down into their stomach. Something else that babies can be born with is something called an imperforate anus. So the upper GI and the lower GI are two different types of tissue, and where those meet, there should be a communication. So when that doesn't happen, then they don't have a normally formed anus. So when the perforation doesn't take place, the lower end of the GI tract just ends in a blind pouch. So there's a variety. It could just be like a really, really tight anus, or there could be no anus there at all. So they need to go in and open up that area so that the stool can adequately leave the body. Sometimes it's something that's quite obvious because they don't look like they have an anus, and sometimes it's just really, really tight and they need to dilate that area. But this is something that they can also be born with. So we talk about, if you guys are ever going to do OB, one of the things that you look at is if the baby passes a stool in the first 24 hours. So obviously, if they don't have a normal anus, they're less likely to be able to pass that stool. So if they're not passing stool in the first 24 hours, you need to take a good look at them to see what's going on. This is something that could be presented as an imperforate anus with not passing stool in the first 24 hours. So they do need surgery. Sometimes they can just go in, the connection is there, but it's too tight, so they can go in and dilate it. Or sometimes they need to do a colonostomy. Does anyone know what a colonostomy is?
They make a hole where the colon is.
Yeah, so they pull the colon up to the skin. So they'll disconnect the colon from the anus and they pull the colon up to the skin, and then the stool leaves through the ostomy site. So they'll have a place on their stomach where the tip of the colon is, and the stool will drain through there. So they put like a bag over that ostomy site and their stool drains through there. So sometimes they're able to just kind of dilate or pull the colon down to the anus, but sometimes they have to pull the colon up to the stomach on the skin, and then have the stool drain through that ostomy site. Something else that babies can be born with, but it's not necessarily diagnosed right as a newborn, is something called pyloric stenosis. This is one of your discussion questions. So pylorus is the connection between the stomach and the small intestine. So when they have the stenosis, it's too tight. So then they have projectile vomiting. So they're not able to, what they eat is not able to leave their stomach and go down into their small intestine. So this is like, it's not spit up, it's not like normal vomiting, it's really, really projectile vomiting. So this is the primary thing that you're gonna see with pyloric stenosis. And sometimes you'll have this olive-shaped mass in the abdomen, but like the classic sign of pyloric stenosis is this projectile vomiting. And so this pyloric stenosis is something they treat with surgery also. They tend to be a couple months old before they're diagnosed, and it's more common in boys than in girls. So then celiac disease, you guys probably know somebody that has celiac disease. So celiac disease is an inability to digest gluten. So, you know, for your test, you do need to be able to recognize which foods do not have gluten. So you need to be able to make sure, you know, that they're not eating gluten. So gluten is in wheat, barley, oats, and rye. They can have rice, they can have vegetables, but these are the things that they cannot eat. So you need to, you know, you're going to do a lot of dietary instruction with people if they have a child with celiac disease, because it's really the primary treatment is dietary modification. So when they have celiac disease, the repeated exposure to gluten damages the villi of their intestines, so then they're not able to absorb other nutrients well. They frequently present with abdominal distension, and they can also have changes in their stool pattern. So it can present from a wide range of symptoms. Sometimes they don't even know that they have it. They still did not absorb nutrients well, but it can take a long time for it to get diagnosed. And sometimes they'll actually have like a systemic rash on their body when they have the gluten intolerance. So it's one of those things that's kind of a lot of times it's a diagnosis of exclusion. If they're not gaining weight well, if they have this rash that won't go away, they can be worked up for celiac disease. It's definitively diagnosed with a biopsy of the small intestine. It's not uncommon that they present with failure to thrive, being irritable. Since they have malabsorption problems, they can have these bulky, frothy stools. You can do the small bowel biopsy as the definitive diagnosis. And the main thing is it's diet modification. They have to just avoid gluten. And so they are going to be managed by a whole team, including a nutritionist and a dietitian that helps the parents make good food choices. So every time I do this talk, I think I should move this slide up to the imperforate anus. So Hirschsprung's is something else that they can be born with. This is a disease that's more common in children that have Down syndrome. So I don't know if you've ever seen a kid that has Down syndrome, but they tend to be really floppy and they don't have good muscle tone. And that's how I remember Hirschsprung's, because this is the same thing. They don't have the same innervation to their colon. So they don't have the ability to really have normal peristalsis where their bowel moves. So peristalsis is when your bowel moves in and out, and it kind of pushes and squeezes stool down your intestine. So they end up with constipation because they don't have the same innervation of their intestine. So there's a wide range, like a lot of things. Sometimes they are intermittently constipated, and sometimes they fail to pass stool in that first 24 to 48 hours. So there's a wide range of symptoms. Sometimes they just have these ribbon-like feces or ribbon-like stools because they're just not able to squeeze their colon the same way. It is more common, like I said, in Down syndrome. Sometimes they need to do dilation to try to help make it easier. for the stool to come out. They can have exacerbations. Sometimes they end up on laxatives, etc. This is another one. So the imperforate anus, you would suspect it if they didn't have the stool from the first 24. The same thing, Hirschsprung's, if they're not passing stool when they're a newborn, they need more of an evaluation. If they're not diagnosed right away as newborns, the ribbon-like stools, constipation, abdominal distension. And it's not uncommon that the parents just think they have constipation and treat them with laxatives, etc., before they're ultimately diagnosed. So it can lead to an intestinal obstruction, which then can lead to septic shock, and they can get really sick. It's one of those things that, like I said, there's a pretty wide variety of symptoms. Sometimes they just need like diet modification and stool softeners, and sometimes they actually need surgery to help them out. But since it's really an innervation problem, if they have surgery, that would be to like an ostomy to pull it up to the stomach, but usually it's more of a modification of their diet, etc., to help them just with their peristalsis and help the stool move down. They can also be born with something that's called Meckel's diverticulum. And this is just like an outpoaching in the small intestine. It leads to bleeding. So the most common thing that you see is going to be bloody stools. And you're going to see this more often in boys than in girls. And they do a surgical repair. So hernias, you think about hernias a lot with adults, but babies can have hernias also, particularly an umbilical hernia. So that would be like the intestines poking out through the umbilicus. So generally speaking, hernia is just an outpoaching of the intestines through the muscle wall. So if it's something that's reducible, meaning that you can press on it, then that's not as concerning. But if you're not able to push it back in, then you're going to be worried that the intestines are strangulated or not getting blood supply. So that's a medical emergency. They can prevent with abdominal pain, vomiting. If they have evidence of an incarcerated or a strangulated hernia, then they need emergent surgery. So those are the things that you can be born with. Does anyone have any questions on the different GI problems that you can be born with? You guys are quiet today. In addition to the things you can be born with, there's also your basic, what we consider your GI problem is going to be your vomiting, your diarrhea. Constipation is another one. So, just kind of being aware that kids are kind of prone to GI problems. They vomiting and diarrhea, gastroenteritis can be quite contagious. They can get easily in daycare, etc. So if you have a child that has a gastroenteritis, your primary nursing care is making sure they're not getting dehydrated and making sure their electrolytes are stable. You're going to do good ins and out monitoring, so making sure you're paying attention to what they're eating and how much they're peeing and pooping. And then, there's a lot of education in terms of making sure parents know how to store food properly and doing good principles of hygiene and hand washing, etc. at home. So I think we all know what vomiting is. So, kids that vomit can get dehydrated. They can also develop an acid-base imbalance. Does anyone know what sort of acid-base imbalance you develop with vomiting?
Metabolic acidosis.
Alcosis.
So we have a debate. Is it acidosis or alkalosis?
It's alk because acidosis is coming out the ass.
Yeah, very good. So you guys need it. This is the best way to remember it. I think that was Matthew that said that. So yeah, so acidosis out the ass or base out the butt. So when you have diarrhea, you lose a lot of your base. So if you have not enough base, you have an acidosis. And when you vomit, you lose hydrochloric acid. So when you vomit, you lose your hydrochloric acid. So then you're losing too much acid, and it's the inverse. So if you're losing too much acid, you have an alkalosis. So very good. You do need to be able, this is common to have like an NCLEX question to be like, if it's vomiting, what type of acid-base imbalance is, and if it's a diarrhea, what type of it is. Obviously, sometimes kids have both vomiting and diarrhea, but I just want to put that out there, that it's frequently in the standardized testing rule to try to get you to remember which one is it, which sort of acid-base imbalance it is. Sometimes, when you vomit, you can also develop an aspiration pneumonia. So you vomit and then you swallow some of that vomit back into your lungs. Sometimes it can also be a more serious problem. Like you'll see vomiting in kids that have increased intracranial pressure. So just always be on the lookout if they've never had a fever or any sorts of problems that would make you think that they should be vomiting, and then they start vomiting. It could be related to ICP, and sometimes it's related to feeding techniques. So what do you think about feeding? What type of feeding could lead to vomiting?
Overfeeding.
Overfeeding and not burping, or having them lie on their back. This is something you're specifically going to see with babies and that are being bottle fed. It's not, you don't really normally see like overfeeding in breastfed infants, but if you are, you have the baby flat on the back and you just put the bottle in their mouth, or you do bottle propping, and you're not burping or you're overfeeding, then they could really start to vomit. So some things you teach about are carefully burping the infant. You don't want to, you can put them on their side after they eat so that if they do vomit, they're not likely to aspirate it. And then if they're really vomiting a lot, this is where you're going to be worried about maybe they might need some IV fluids. So diarrhea without vomiting, usually you try to treat that at home with electrolyte replacement. But if they're not able to keep anything down, they're more likely to need IV fluid and come into the hospital. So if they do vomit, you need to make sure that you're documenting what it looks like, how often, and if you give them any medications, what time you gave the medication, and if it was effective. So both vomiting and diarrhea are pretty common in kids. So it's a sudden increase in stool that's pretty liquidy. Normally it can be like a greenish color. It can be viral, bacterial, or parasitic. And it's not uncommon that kids kind of have diarrhea for several days. Sometimes it really freaks parents out. So we call it chronic diarrhea if it lasts more than 2 weeks. But if you have a kid, all of you that are parents here, if you've had a kid that has diarrhea, sometimes it just lasts for several days. So you need to make sure, that they're generally feeling okay, that they're still peeing, and then you're keeping up with their fluids, but to be aware that it's not that uncommon for them to get diarrhea and then have it last for several days. And the main thing that you do is you try to stay on top of their fluid intake. If they're losing weight, if they have a fever, if they're really not interactive, these are kids that you might need to have them come into the hospital. You may be being able to pay attention to evidence of dehydration. If they still have their fontanelle open, is the fontanelle sunken? That's a sign of dehydration. Dry skin, dry tongue. And then Matthew, excessive loss of bicarbonate from the GI tract reloads in acidosis. So this is the point here of trying to remember which one is acidosis and which was an alkalosis. So the base out the butt, or acid, it's related to your ass. So however you want to remember it, but it is common for them to ask you. You lose a lot of bicarb, which is your base, when you have diarrhea, which causes an acidosis. On the opposite end of the spectrum, we have constipation. So this is another thing that when you work in pediatrics, you're probably going to see constipation. You almost always start with diet modification before you move towards any sort of laxatives or enemas. We really try to just encourage, a lot of times it's encouraging less milk intake, trying to increase fiber intake, encourage a little bit more water intake. A lot of times will help with constipation. So it's defined as fewer than 7 bowel movements in a 2-week period. So a lot of times parents will say their kid's constipated, but they don't really meet the definition of constipation. So just making sure that parents know that, you don't have to have a bowel movement every single day, but you really want to do things, evaluate their diet and exercise habits, and try to get them to have bowel movements on a regular basis. And doing things like increasing water and also increasing their fiber intake is a good way to help them If you do give anything, it would probably be a stool softener. We don't do, very infrequently do we do laxatives or enemas in children. So we've talked a lot about how kids are different than adults throughout this class, and this is going to be true in terms of their risk for dehydration and their risk for electrolyte imbalances. So they lose a lot of water through their skin, so they're more prone to dehydration than adults. And they also still, especially under the age of 2, they have those immature kidneys. They're not able to concentrate their urine as much, so that also makes them at risk for dehydration. They also have a higher metabolic rate. Means they need more calories per their body size. So all of those influence why it is that they're a higher risk for dehydration. So, you know, kids they can just go from being well to being sick very quickly because of their inability to really manage their temperature and their fluid balance. So just really, in particular for an infant, just to really remember that you have to pay a lot of attention to their intake and output. And if they're not peeing normally, or if they're staying dehydrated in any way, you really need to bring them into the emergency room. They might need some IV fluids. So, you know, we almost always start with our oral fluids at home, but if they're vomiting and they're really not able to keep anything down, they probably need to come into the emergency room for some parenteral fluids, which are called IV fluids. One of the main ways that we figure out how dehydrated they are is by their percent of body weight that's lost. So usually, you know, mild dehydration is going to be less than 4%. They might not have any symptoms, and then you're going to really see signs of dehydration when they have this fluid volume deficit of around 10%. You don't really necessarily need to focus too much on the exact numbers. The main thing that I want you to really remember is that when you're young, particularly under the age of 2, you're really at risk for dehydration, electrolyte imbalances, and that's kind of that age group where you're going to want to make sure they come to the hospital quickly if they're showing any signs of dehydration. There is different types of IV fluid that we talk about: isotonic, hypotonic, and hypertonic. Have you guys talked about this in your med surg class? Does anyone give me an example? Can anyone give me an example of isotonic fluid and what it means to be isotonic?
Lactated ringer.
Lactated ringer is isotonic fluid. Very, very good. And what does it mean when you say isotonic? What does that mean? How does that infect, you know, the blood? And how is isotonic different than, say, hypertonic?
It's equal to your body.
Right. So you're not going to have fluid shifts. So something like lactated ringers, normal saline, it has the same concentration of solutes as your blood. So then if you give it to somebody, there's not going to be fluid shifts around your blood cells because it's the same concentration. So hypertonic is more concentrated, so it's going to pull fluid out of your cells, and hypotonic is less concentrated, so then fluid enters your cells. So you just need to be aware of what's going on with your patient and what their electrolyte balance is, et cetera, so that you can make sure they're getting an appropriate IV fluid. So maintenance fluid is just replacing normal water and electrolyte losses. But if they need boluses, et cetera, they could have a deficit. So you need to make sure that, you know, your patient is getting the appropriate IV fluid for what's going on with them physiologically. If they have a significant deficit, they could go into shock. And so you need to be paying attention and making sure that you're up to date on what their fluid balance is, and making sure that they're getting the appropriate IV fluid. And then one of the things that we worry about a lot is potassium. So potassium is excreted by your kidneys. So generally speaking, we don't put potassium in the IV fluid until they're starting to pee. So if they're having, you know, significant dehydration and they're not having normal urine output, you don't want to be giving them any potassium because they could develop hyperkalemia. On the other end of the spectrum, You can have patients that have overhydration, which is mean they have too much fluid on board. Sometimes they can get overhydrated because their fluid, their IV fluid is running too high in the hospital. Sometimes, you know, kids that are neurologically not normal, sometimes they just drink too much and they can end up overly hydrated. You would expect them to develop edemia. So anasarca is generalized edemia. Albumin or protein is it gives your blood oncotic pressure, so it keeps fluid in your blood vessels. So if they're really fluid overloaded, they would have like a dilutional effect and they would have a lower protein level. So this doesn't happen as often, but you just need to be aware that you can have both ends. You could have dehydration or you can also have overhydration. So this is a question for you. What is an indication of overhydration in a 1-month-old infant that's on intravenous fluid? A heart rate of 100, lethargy, a bulging fontanelle, or increased urine output? What do you guys think?
Would it be the bulging fontanelle?
Yeah,
And then
very good. So heart rate is normal, lethargy, not necessarily. Bulging fontanelle, you also see this potentially with meningitis, but this is going to be a sign that they have too much fluid on board. Good job. So, you know, if they have overhydration, they might end up on Lasix or something to help pull the fluid off. Sometimes, like I said, it can just be related to the fact that they got too much IV fluid. You need to keep a close eye on their electrolytes. And you need to be thinking about, you know, what their electrolytes are. So if they're already hypertonic, you shouldn't be giving them something that's really salty. And if they're hypotonic, then you are not going to give them free water. So just to be aware of the fact that when they come in, it's not just their fluid status, it's also their electrolyte status. And then you're going to choose fluids that are appropriate. So hypertonic, they're more likely to have like a high sodium, and hypotonic, they're more likely to have a low sodium. So making sure you're targeting their fluid replacement based on what's going on with their electrolytes. Whenever you're doing either overhydration or underhydration, you're going to be paying really close attention to their weights, their vital signs, you know, any changes in urine output. All of these things are things that you're going to see with, you know, changes in weight and urine output, et cetera. You'll see with both overhydration and underhydration. And then, you know, staying up to date on their electrolytes, monitoring their labs. So unfortunately, when we talk about pediatrics, we always have to be thinking about abuse. It's always possible. One of the ways that neglect presents is failure to thrive. So failure to gain weight, or you lose weight too quickly. Sometimes it could be what we call non-organic. So this is the parents not feeding the baby enough, and sometimes it can be organic. So there's something wrong that's causing them to have an increased caloric needs, or maybe they're not able to absorb things well from their GI tract. So it's really important when they come in for failure to thrive that you're non-judgmental, and then you don't assume that it's neglect, that you let the process play out and you do a full evaluation into what's going on. So it's not uncommon if you're working in a pediatric hospital that you'll take care of patients that have failure to thrive. In addition to weight loss, you can expect them to be irritable. Maybe they could have signs of like more complex problems, have neurological problems or spasticity. We've talked, you know, about the growth charts for kids. So the main thing is that they're following along the growth chart. So if a kid's born at the 10th percentile for their height and weight and they kind of stay at the 10th percentile, that's okay. But you really, really start to worry if they're below this 3rd percentile. So failure to thrive is not just thinner than average. It's really this very specific cutoff and being less than the 3rd percentile for their weight. And like I said, there can be a lot of different things that influence it. It could be organic or non-organic. So if they come into the hospital with failure to thrive, it's best that it's really a multidisciplinary team. Sometimes the kid has to be removed from the home. It's one of those diagnoses, they'll tend to be there for a while because it takes a while to figure out what's going on. So if you can have a primary nurse or primary nursing staff that knows the child and the family, that's best. So even if there is some evidence of neglect, you still want the mother to be there as much as possible, assisting in the care, doing a lot of teaching. you never really know what's going on. So you want to make sure that you're being as non-judgmental and supportive of not just the patient, but the mom also. And then trying to follow up, if it is end up being because of neglect, what caused the neglect, and is this something that can be addressed and the mom can learn the skills that she needs, or is it going to be more of a social work referral and removing the child from the home? So that always makes me sad. So does anyone have any questions about Failure to Thrive, or what you would do as a nurse if you were taking care of a baby that had failure to thrive? So appendicitis is something that you can see in kids. I think most of you guys are probably pretty familiar with appendicitis because you also see it in adults. There are some things that you really need to be able to point out about. So the classic thing is that right lower quadrant pain. So it's different than other types of abdominal pain, then it's really localized to the right lower quadrant. And it can become quite serious, particularly if it ruptures. They can develop septic shock or peritonitis. So you definitely need to remember that it starts with the right lower quadrant is the thing that kind of makes it different from other types of abdominal pain. And you need to be able to recognize this point here, this McBurney's point. That's the right lower quadrant. So you need to be able to remember those two things. Guarding means that they don't want you to press their abdomen, and then rebound tenderness is you press down and it doesn't hurt that bad, but then as you're lifting your hand up, that's when they really have the pain. So you really should be able to sort of recognize these three characteristics as really being common characteristics of appendicitis. So frequently they come into the emergency room with vomiting and the abdominal pain. Sometimes they have to do an ultrasound, but a lot of times they can diagnose it in the emergency room with sometimes they have to do a CT scan, but usually they can diagnose it with an ultrasound. If they do have an appendicitis, then they do need to have surgery. They're going to come out of surgery, as long as it wasn't ruptured, they tend to do pretty well coming out of surgery. If it was ruptured before they had surgery, they can be pretty sick with, septic shock or problems with fighting infection. Has anyone had appendicitis? Had your appendix removed? Known anyone with appendicitis? No? Have you guys taken care of anyone with appendicitis in the hospital?
My son had his removed.
Yeah, what was he like when he had it?
Well, it was kind of rapid, so it was like he didn't tell me he was in pain for a while, and then by the time he did, it was like it had moments before it would burst, and then it did burst. So everything that would go wrong went wrong.
Carolina, I'm sorry to hear that. Is he okay?
Oh yeah, he's fine. They removed it, and then he got abscess, so then they had to put a drain in.
Oh.
Then they released him, and then it built up scar tissue that locked up his bowels, so he had to go back, get the scar tissue removed. Now he's fine.
Oh my goodness. Sounds like quite the ordeal. Was he vomiting a lot too, or is it just painful for him?
He was vomiting, yeah.
Yeah. So that's like the classic sign. So I'm sorry that you had to go through that, but I think most of us in our lifetime, we're going to know somebody. Appendicitis is pretty common. So certainly, Carolina, I'm sorry he didn't say anything to you until he was really sick. But certainly if they have that really bad pain and the vomiting, you should bring him into the emergency room because it could always be appendicitis.
Yeah, he's 16, so that happened when he was 15, and he didn't even tell me he was vomiting. He said he thought it was just because he ate too much.
Boys. Well, thanks for sharing. So something that you'll see a lot more in kids than you're going to see in adults are worms. So pinworms are the most common. So these kind of look like little white threads, or sometimes like a really, really tiny grain of rice. and you see them around their anus. This Scotch tape test, you literally put Scotch tape around their anus, and then when you take the Scotch tape off, you can see the little worms. So it kind of grosses families out. It's unfortunate. I mean, I understand why it grosses them out, but you just need to be aware that it's super contagious. And it's really, the worms lay their eggs outside the anus, and then they have to ingest the eggs to get the worm infection. So this is like kids that scratch their butt and then lick their fingers or stuff like that. That's how it's spread. But you know, kids suck their fingers a lot. So it spreads quickly throughout daycares and homes and stuff like that. So it doesn't necessarily mean there's like a hygiene problem in the house. It's just that kids put their fingers in their mouth. So then if one kid has it in the household, it can spread to all the other kids easily. You do need to treat it. All the kids in the house will get treated. And in contrast to pinworms, so when they have pinworms, they're usually not very sick. The main thing is their anus itches a lot and it's annoying for them. But when they have roundworms, they can get really, really sick. So this is something that you're gonna see more often in migrant farm worker camps or people that don't have indoor plumbing. So the eggs from the roundworms live in the soil. So if the kid's digging in the soil, eating in the soil, they can get the roundworm. And this is, you know, these are like these really big worms that you see on like the Discovery Channel, where they're not able to digest their food well. They end up vomiting, diarrhea. They can be very, very, very sick. So you don't really see these roundworms very often in the United States. If you do see it, you almost always see it somewhere where they don't have indoor plumbing and the kid's been digging in the dirt where the eggs can live. So, you know, the main thing for parent teaching is making sure they know that the eggs they live in the soil. So you need to make sure that you have proper separation of feces from the dirt where the kids could play. And it's really more of like in controlling the environment more than anything to prevent the infection. So kids can also poison, they can get into poisoning. This is one of those things that you need to make sure that all the household cleaners are put away. A lot of times things smell good or they look good, like those Tide laundry detergent pods look like candy to kids. So just to be aware that household cleaners, stuff that they can find in the household, a lot of it can be really dangerous. So you need to make sure that all that stuff is kept away from the kids and you're watching them. Sometimes you can figure out what they might have consumed, ingested based on how it smells. So you don't really need to necessarily go through and memorize this chart, but just to know that when you are worried about an ingestion, that making sure that you recognize like how much they vomited, what the vomit looks like, what the vomit smells like, all of that is important in trying to figure out what they took. And if you can give any of that information, if you have to call poison control, it's helpful. So all parents should have this poison control center like on the refrigerator or near their phone or someplace. It's a nationwide number and the poison control people are really knowledgeable. So if there's been any concern at all about ingestion and the kid seems stable at the moment, you can have them call poison control and see if they need to come into the emergency room. Sometimes, you know, in the emergency room, they will give activated charcoal that binds to whatever's in their stomach. This is not something we recommend parents do at home, and it has to be done within a certain time frame. By the time it's left the stomach, the activated charcoal won't do any good. So there's 1 hour post ingestion where you could do something like gastric lavage or charcoal. If it's beyond that, whatever they've ingested is moved through their GI tract. So parents a lot of times think that, you know, they need to keep their prescription medications locked up, but their over-the-counter medications are, you know, not as dangerous. Something like Tylenol can be really, really dangerous in high quantities. So just because it's over the counter doesn't mean it's not dangerous. You just need to make sure all of your medications are put away and kids don't have access to any of it. Also have to be worried about herbal supplements, household cleaners, etc. So there are all sorts of things that kids can get into. Their cleaners, the medications, your They can also eat poisonous plants. They can be stung by insects. They can be bitten by a snake. Lead poisoning is something we see. Lead poisoning in older homes most often. If they have any, the paint is chipping and they eat the chipped paint. And then carbon monoxide, we really encourage people to have a carbon monoxide detector in their home. So does anyone know why we worry so much about lead poisoning? Have any of you guys that are parents had have your kids' lead level tested? What's the danger with lead poisoning?
Developmental delays.
So it can cause brain damage, right? So it can have lasting effects on their central nervous system, particularly their brain. So when I worked in pediatrics, we always did like a lead screening tool. And if they were living in older homes, et cetera, a lot of times we would just go ahead and test their lead level. So it's one of those things you need to be aware of. Kids are at higher risk for CNS problems because their brain is still developing. So, inner city areas, older homes where they might have crumbling paint. Also, if the kid digs in the dirt, because you're more likely to find the lead-based paint in the dirt. So you need to make sure it's something we take seriously, testing their lead level. In the beginning stages, it's kind of just like they don't feel well, they're weak, they're irritable, but then the later stages is when you would expect them to have the nervous system involvement. So you want to make sure that you're paying attention early on and not letting it get to those later stages. And they do have a chelation therapy where they can remove the lead from the body. And in addition to poisoning, you just also have to be worried that they could aspirate a foreign body. This would be something like a coin or something that they eat. Most of the time it just passes through the GI tract without difficulty. But you do need to make sure that parents let you know, and then if they're having any problems breathing, et cetera, that you follow up and get an x-ray, because it almost always goes in the esophagus, but it doesn't necessarily. So you need to figure out where it is. Do you guys have any questions about the GI tract? Okay, we have one more Kahoot, and then you guys will be free to go. I will post a Kahoot instruments that will help you guys with next week's quiz, since you guys are gonna not have class on Monday. You guys will likely be taking the quiz with somebody else. So I'll make sure that I give you guys the best possible chance to do well on your quiz. So pay attention to the announcements. I'll post the Kahoot this week so that when you go to class week, you guys can take your quiz.
So I have a quick question. What do you mean by when do we know when or where the class to jump on for next week?
Yeah, thank you for asking. So you have the option. So I'll tell you, you have two options. You can either attend another teacher's class, and there's something called the Course Cafe. So when we get done with class today, I'll post in the Course Cafe the different teachers' classes and their Zoom information. And I want you to tell me by Wednesday which class you're going to go to, if you can go to a class. If you can't go to a class, you need to let me know, and I'll give you a homework assignment where you can watch my Tuesday lecture and answer some questions, and then I'll give you credit for class, and then you'll have to arrange with me a day and time to take the quiz. So it's going to be easiest if you attend somebody else's class, but if you can't attend somebody else's class, you just need to touch base with me and I'll give you an assignment and we'll figure out a day for you to take the quiz.
Okay, perfect. Thank you.
You're welcome. Okay, what finding in a newborn is suggestive of a transesophageal fistula? Failure to pass meconium in 24 hours, papillary mass in the sternal area, visible peristalsis across the abdomen, or choking on the first feed. All right, very good. Choking on the first feed. So failure to pass meconium, we think about imperforate anus or maybe the Hirschsprungs, and then the palpable mass. That's in the, if it was in the olive size mass, pyloric stenosis. So good job. Yeah, choking on the first feed is your right answer. So a child is brought to the clinic with vomiting for the past 2 days. What acid-base imbalance would the nurse expect? Alkalosis, acidosis, hyperkalemia, or hypernatremia? Very good. I'm so glad you guys are paying attention. So vomiting, alkalosis, nice job. So the nurse is interviewing parents of an infant with pyloric stenosis. What would the nurse expect the parents to report? Constipation, projectile vomiting, poor appetite, or diarrhea? Very good. That's the projectile vomiting. Nice job, you guys. What instructions will the nurse give to parents about preventing the spread and reinfection of pinworms? Keep child's nails short, dress the child in loose fitting underwear, clean the bathroom with a bleach solution, or watch the bed linens in cold water. So I'm impressed some of you got this. So it is they ingest the worm. So keeping the nail short kind of makes it less likely they can have anything on their fingers that they could spread to their GI tract. So keeping their nails short is the best way, and also trying to not have them suck on their fingers. So a 2-year-old experiences constipation frequently. Which food would the nurse recommend for the child? Cooked vegetables, pretzels, whole grain cereal, or a yogurt? All right, so good job. It's the whole grain cereal. Raw vegetables are a good source of fiber. Once you cook them, that fiber is not, it kind of loses the fiber through the cooking process. So you want to, the whole grain cereal is your best answer. So mother calls the PCP office because her child swallowing dishwashing detergent. What's the most appropriate action? Inducing vomiting by giving the child syrup of IPEC, give the child activated charcoal mixed with orange juice, give the child milk to soothe the mucous membranes, or take the child to the local emergency department. Yeah, so good job. You're not going to have the mom induce any vomiting or anything like that at home. They need to be seen in the emergency room, and they can make a decision from there. So the nurse has reviewed dietary restrictions for celiac disease. Which grain will the nurse advise that celiacs can eat? Wheat, rice, barley, or oats? All right, good job. So they can eat rice. Nice work. So why are infants more vulnerable to fluid and electrolyte imbalances than adults? They have a greater percentage of their body water is extracellular. Water needs and losses per kilogram are lower. they have a smaller body surface area in proportion to their weight, or they have a slower metabolic rate. So this one was tricky. They have more of their water as extracellular, so they're more likely to sweat and lose fluid through their skin. All right, last one. So this one we're actually going to skip because I don't think you guys need to know that. I'm sorry. I'm going to go ahead and skip it really quick. All right, podium time. Christy did well in the last one too. Dallas, who's Dallas? All right. Very good job, you guys. So when I post the lecture, I'll post the Kahoots, and then to help you get ready for the quiz next week, I'll post a separate announcement with the Kahoot. So keep a lookout today for it's called the Course Cafe. Well, I'll post the times and the Zoom numbers for the other teachers. So you have option number 1 is to attend somebody else's class and take the quiz with that teacher. And option number 2 is to watch the video recording of my Tuesday class and answer a homework assignment, and then also follow with me to take your quiz at a different time. Does anyone have any questions about that? Okay. If you don't have any questions, you're free to go. If anyone has any questions, you're welcome to stay on and ask me as your classmates leave.
Have a good day, everyone.
Thank you. Have a good day.
Bye-bye. All right. Do you have any questions, Rachel? Do you need anything, Rachel? She's frozen.